Okay, we'll just give a few minutes to welcome our participants before we go right into the webinar. Welcome to everyone who has joined.
Good morning, everyone. Welcome to the second MNCH Expert Dialogue series, hosted by FIRAT. FIRAT is a multidisciplinary working across Nigeria and Rwanda, committed to advancing public health through high-quality research.
Okay, welcome to everyone who has joined. I think we'll go right into the webinar. Hi T, I don't know if you can hear me. Can you please go ahead? Can you hear me, Hi T?
Good morning, everyone, and a warm welcome to the second edition.
Okay, and our second speaker is trying to join. She has some issues, but she'll join us shortly. Okay, so good morning, good afternoon, or good evening, wherever you're joining us from. Welcome to the second installment of the Expert Dialogue series, where we'll be discussing salient issues regarding maternal and child health. Today, we have two very brilliant minds that will be interacting with and asking questions. Let me not, we'll still go into that and introduce our speakers. So, um, the topic for today's discussion is early years, big impact, managing health risks from 0 to 5 years. You know, I'm really honored to moderate this crucial discussion and under the auspices of FIRAT. FIRAT is Foresight Institute of Research and Translation, which is a cutting edge private research institution whose vision is to transform lives through research, innovation, and training. And in this installment today, we'll be discussing about child health. Basically, the overarching discussion is centered around maternal, neonatal, and child health. And the latest evidence indicates that chronic and elevated levels of maternal and child mortality, especially in LMICs, have they, they are largely preventable, and it really highlights the need for concerted efforts to improve child maternal, neonatal, and child health outcomes. Recently there has been a surge in research with very valuable research findings, interventions, and policy updates. So there's that crucial need to be able to bridge the gap, like we were saying in the first installment, that there's that research, there are the practitioners, the policymakers. So what we are trying to do is to bridge the gap between the researchers, the practitioners, and the policymakers so that we can foster discussion. We are using this as a platform to foster discussion and disseminate evidence-based solutions to advance maternal and child health, to reduce mortality and morbidity. And we know that over the past few decades, we've progress in global child mortality. It's been said that child mortality has been halved since 2000, and more mothers and children are surviving more than ever. In as much as this sounds like good news, there are still vast disparities that are occurring in LMICs, you know, and children in LMICs face up to 15 times the risk of dying before their fifth birthday compared to those in high income nations. There are different causes. Our brilliant panelists and guest speakers will be taking us through some of those causes of morbidity and mortality in children. But one thing that is notable is that vaccines have been said to be one of the greatest public health discoveries of the century that has saved millions of lives and continue to save millions of lives every year. But this has also come under, threat with the advent of misinformation, disinformation, malinformation. There's that gradual reverse in the hard won gains, and we need to be able to cover all of this and bridge the gaps. There's also that talk of vaccines linked to autism. These are things that are starting to increase vaccine hesitancy among caregivers and parents, and these are things that are undermining the gains in mortality, in reducing mortality and morbidity for children. So this conversation is not just about survival, it's about giving every child the chance they need to thrive, being able to confront these threats that face children, and being able to give every child a chance to achieve their highest potentials. So I thank every single person for joining us. Thank you for being here. We explore what it truly means to protect and promote health in the earliest years. So without much ado, I will be introducing our panelists for today. I will start with Dr. Navneet Bichha. I hope I pronounced that right.
Yeah,
Okay. Um, Dr. Navneet is an amazing, okay, let me not go to the personal on how we met, but he's a brilliant researcher and is an expert in vaccinology. I would just be reading his citation. He's currently the senior program officer at the England Trust International in New Delhi. He has an MD from the BP Koirala Institute of Health Sciences. He has an MPH in tropical disease and implementation research. He holds a postgraduate diploma in vaccinology and infectious diseases from the Institute Pasteur. He also has a fellowship in vaccinology from the International Vaccine Institute, the Christian Medical College, University, Geneva. And he also has a fellowship in COVID-19 recovery for childhood immunization at the Sabine Vaccine Institute. He's a physician scientist from Nepal with a wide range of experiences in the field of vaccinology under the domain of vaccine safety surveillance, implementation research, and clinical trials for vaccine development in Nepal and India for over 7 years. Like I said, is currently the at the England Trust International as a senior program officer, where he leads global vaccine safety surveillance study funded by CEPI and DCVMN, along with the phase 4 safety study for CER-VA-VAC, which is the quadrivalent HPV vaccine funded by the Serum Institute of India. He is a WHO TDR scholar in implementation science, and he was highly instrumental in conducting various implementation research in the scope of vaccine hesitancy, polio immunization programs in India, and in evaluating new vaccine introductions such as COVID-19 and the typhoid conjugate vaccine in Nepal. Dr. Bichha has also served as an investigator for the development of the WHO pre-qualified typhoid conjugate vaccine, Sky Typhoid, the simplified cholera vaccine, and COVID-19 vaccines in Nepal in collaboration with the International Vaccine Institute, South Korean Biosciences, and the Sanofi Pasteur and EU Biologics. So let's please put your hands together for as we welcome the amazing Dr. Bichha for today's Expert Dialogue Series. You're welcome, Dr. Bichha. Would you like to say some
I,
opening statement?
I'm really honored. And thanks for having me here. And it's a very important topic for today. And you have set the scene so beautifully that I can give my expertise on this current hot topics of childhood deaths and also in its implementation with vaccines.
Yeah, thank you so much for honoring us.
Thank you.
And our second speaker for today is Dr. Angela Ulotu Leonard. She is a pediatrics and child health specialist with over a decade of expertise in pediatric neonatal care and infectious diseases. She currently works in the Ministry of Health at Reproductive, Maternal, Newborn, Child, and Adolescent Health section in the Newborn and Child Health Unit, providing technical expertise on neonatal and child health services nationwide. Previously, she worked at Mbeya Zonal Referral Hospital as a coordinator of pediatric outpatient services, where she established integrated pediatric care. She has also served as coordinator of vaccine preventable diseases for 8 years, mentoring healthcare workers and improving surveillance systems. She has been a consultant in UNICEF in vaccine management specialist for 1 year. She has over 8 years of experience in neonatal care units, and she has led the establishment of various neonatal units, trained providers, advised on neonatal equipment, and she has contributed to several research as a principal investigator, especially in a study on iron deficiency anemia in infants and also multi-country maternal immunization projects. She also holds a Master's of Medicine in Pediatrics and Child Health and also currently pursuing a Master's in Public Health via distance learning. So please let's welcome Dr. Angela Ulotu Leonard. Please, if you're here, can you unmute and say a few words?
Uh, Good morning, everybody. Thank you very much, Bisola and the team. I'm sorry that I was late, but I think now you can hear me very well. I'm
Yes.
very, very honored to be here and to meet you again. Thank you.
Thank you so much. Thank you, everyone that has joined. And we know some people are having some challenges joining, but I believe that they will be able to surmount the challenges. So I would start right away with the questions. And okay, they say ladies first. So my first question will go to Dr. Angela. And I would say that based on your experience and your, I would just like for you to share with us what are the biggest health risks facing children today?
Uh, Thank you very much. So, uh, the and globally, we have so many issues that are concerning the children, but there are those that are critical, and as global, we can handle them. But due to a lot of issues, we can't handle them. But commonly, we have in the children, we have the preventable causes, and these preventable causes neonatal condition, which account for almost 47% to 50% of the causes of mortality in children under 5. But also we have, when we say neonatal condition, are the commonest one that like Beta speaks as the child will be born, he will not be able to be resuscitated very well. And this is just because of the capacity of healthcare workers. Um, but also we may have prematurity. These are preventable causes, and the sepsis. Uh, Others are like uh, pneumonia, malaria. These are also have been declined and the current data, but there are still countries that have a lot of the burden on these communicable diseases. But in all the big perspective of the pictures in the globally, we have the malnutrition, in which malnutrition is like underlying factor that when you prevent it, other opportunistic issues are not coming up. So if you prevent malnutrition, automatically a child will with pneumonia may be improved rather than just dying just because of malnutrition and pneumonia. So those are the quite common, and fortunately that these issues, the vaccine has taken the place globally and has showing a very big improvement in the communicable diseases. So we talk about diarrhea diseases, we talk about pneumonia, we talk about measles. These are the preventable causes that have been have been helped by the vaccine. Yeah, thank you.
Thank you very much. So, if I understand right from what you have said, many of these causes are preventable or they are infectious in nature and, of course, preventable. Is that right? And is this peculiar only to LMICs or the picture is the same worldwide?
Can you repeat? Sorry.
I said from these causes of the biggest health threats facing children, are these causes, the pneumonia, malaria, and other infectious causes, are they specific only to LMICs or that's the picture worldwide?
Okay. So they are more common in the low and middle income countries, but still some of the issues are also seen in developing countries. So when you talk about the uh, communicable diseases, you could see like malaria, pneumonia, diarrhea. The LMIs are the ones who are more affected, and this is because of a lot of issues that are challenging the prevention measures of this. But looking at the developing countries, there is a significant improvement, but there is still the uh, uh, imaging diseases which are coming up in the most of the children, and the imaging diseases that are due to the hesitance and maybe too much public awareness on the some of the diseases, and a lot of effect from the community on how to take the preventive measures. Thank you. Yes,
Sorry,
Bichha.
there was a bit of network issue there. Okay, so I think I would ask this next question to Dr. Navneet. I want to ask, from what Dr. Angela has talked about, these infectious causes of infections and all that, why, we always say under 5 children. Why is it that the first 5 years are
No, Dr. Bisola, please can you repeat the question? I'm not sure Dr. Navneet can hear you well.
Yeah, yeah. I'm sorry, I couldn't get the question.
Yes. Dr. Lubi, please repeat the question for him. We also lost you some minutes ago. I think she also has some internet challenges. Dr. Lubi, are you there? The internet is not treating us well this morning.
Sorry, I had some network issues.
Yes,
Apologies.
yes.
Apologies.
Welcome back.
Thank you so much. Sorry, I was asking Dr. Navneet the question that why is that 0 to 5 years a uniquely critical window in terms of child health, both for and also for public health interventions? Why is this the case?
So, firstly, I would like to say that uh, majority of the events take place within this critical window period. So, most of the 90% of the neuro development process occurs during this time, and this period is crucial in laying foundation for children's cognitive, emotional, and social well-being. That's number one. Number two is children is highly susceptible to infection due to developing immune system, and a high infection load in this first 1 year to 2 years of life will increase the risk of infection in the later childhood, which may
Mm,
lead to a need of systemic antibiotics. So let me give you a classical example of rheumatic heart disease. And rheumatic heart disease is caused, and also post streptococcal glomerulonephritis. These infections is leaded through a recurrent throat infection from group A streptococcus, and that imposes to heart risks and to kidney failures due to these diseases. So this is this period timeline is highly critical because children are susceptible to various communicable and infectious disease. So, like Dr. Angela mentioned, we are seeing a decline in most of the leading causes because now there is availability of vaccines, but we still see that there is this is a timeline where nutrition, uh, good hygiene practices, all of these activities, and with good preventive measures and interventions like vaccines, we can protect and bring in better outcomes in improving childhood mortality.
right. Thank you for that. Before we continue, I would just like that you give a few tips, and I would also ask that question to Dr. Angela. Few tips to for those who are caregivers, that how can they, reduce the health risks that their children pose. For instance, you already mentioned good hygiene, and Dr. Angela and yourself mentioned as well that adequate nutrition, because malnutrition increases the susceptibility to certain infections. So, would you give some other specific tidbits or tips on how to reduce these health risks among their children? For instance, when I had my baby, of course I'm a doctor, but they will still keep saying, "Oh, keep the child away from, other sick children or other sick adults because their immunity is still just developing." And that is something that, it's also something that some cultures integrate, such that women with children under 3 months don't go out. So, what are some of these tips that you can give for those that are caregivers to reduce these health risks among their children?
So, what I believe is that we have program in place. The programs are very beautifully set for different countries. So I think one must realize that for caregivers, they are particularly for under 5 children. We have malnutrition. Nutrition program is set. There's a universal immunization program, national immunization program that is set. There is a MNCI program, which we say integrated uh, childhood, management for childhood illness. So programs are beautifully set in different countries. One must adhere to these programs, and mothers and caregivers, care seekers, should understand that these programs are well set. In case of any urgency, you know they can seek for services from different health providers at the nearest center, and making sure that like for let me give you an example. For in India, we have uh, not only these programs, but right now we are seeing a lot of abuse, child abuse, that is creating a huge impact on mental health of children. So these days, screening of mental health is taking place. So these kind of activities should be intact, and one should realize that mothers especially should realize that am I audible, Bisola?
Yes, we can hear you.
Yeah. So I think these are the tips that a mother or the family members should understand in protecting their children. Is firstly, you have the right vaccine in your country, you have the right nutrition program, and you have, in terms of any infectious disease, you have an integrated management. So you can reach out to these centers. But apart from that, I mentioned about mental health. This is a rising threat at the moment in child, you know sexual abuse. So these things can be prevented when health is promoted among these parents and care seekers. So these are my tips. I think parents should take into consideration.
Thank you, Dr. Navneet. Dr. Angela, would you give us some tips for caregivers to reduce the health risks in their children, especially those 0 to 5 years?
Thank you very much. So for me, I would say like we need like to group the children. We could put the bands. So there are different intervention for the caregiver from the neonatal. There are lots of intervention that can be done during infant period, the under 5 and above under 5. As Dr. Navid said, there are different kinds the intervention that can be done from the Ramka group. But when you look at the caregiver from the neonatal period, the intervention like breastfeeding, the nutrition aspects, they usually really prevent the child from having a risk of severe infection and also give the good immunity to the babies. But when you come to the children, infants period, breastfeeding is also included. But now this is the time period that the child is trying to to get the supposed to receive all the vaccination. So here comes now the caregiver should make sure the infants are receiving all their vaccination as per schedule. This goes up to 5 years, of course, in some of the vaccines. But also, when you look at children who are under 5, what are we giving the babies? What kind of the nutritional products do we give them? So, looking at current intervention, we are facing obesity in under 5, and even the non-communicable diseases are coming up. But also the intervention that can help the babies, like putting the baby I know they will stay in the iPads, in the television for very long time. That's a lot. That gives a lot of risk to the babies because they are now getting the mental illness from there. That is when their brain is being matured. They will get the mental illness from too much watching of the television, too much of iPads. They don't get time for the outside environment and seeing what is. They need to learn from the environment, but they can't learn it from the environment. So, but the child who is about 5 years, these are school outgoing children. There are a lot of intervention that can be done in the school programs, but including intervention of early childhood development. This is not the child who will be staying with the parent only. This is the time that the child will be with the school teacher, will be with other programs outside the at home. That's how you need to make sure that they are in a safe place. There is where we got a lot of injuries, the accidents, the injuries at the schools and all that. So above 10 years, this is adolescent period. But you could see that the intervention are supposed to focus on the age group, I could say, looking at how the children are growing. But the early years have a big impact because this is where the brain is developing. The neurons are more developing in children from during conception up to 3 years. This is the time that we need a lot of intervention that we know what we input to our babies will give a good product later. And this continues up to 8 years. Now we are calling early childhood development interventions that we need
Yeah.
to use them and make sure that they improve the outcome of the children. Thank you.
Thank you, Doctor. So my
Yeah,
next question goes
I, I,
to.
I will just I'll just try to add on here, but I think in respect to immunization, I'll just give an example of Nepal. Nepal has set in place a immunization act. So in 2016, this immunization act came into place. Saying that the children must be below 2 must be vaccinated with all the antigens, and then will be allowed to enter the school. So to enter the school you need to be completely vaccinated. So these kind of interventions, where this kind of act, can help in reducing childhood mortality, uh, through for different childhood illnesses. So this is just one example, but I think Dr. Angela beautifully mentioned there are other health risks, and particularly focusing on early development disorders. She mentioned that breastfeeding is so very important, and the colostrum feeding is so very important that awareness about exclusive breastfeeding is truly needed. People do not know how to latch. Mothers do not know how to latch. So this kind of counselings are also needed in order to prevent different illnesses and also injury. She mentioned about injury. They are susceptible to injury because a lot of things, the cognitive aspects are developed. And one more thing I would like to add on here is that this age group is also vulnerable for poisoning. We see a lot of poisoning cases also. Children picking up things, foreign body aspiration. We're seeing all of this. So, parents must be educated regarding these aspects, and they must be simulated, uh, and must be told, these are the potential health risks, and this is how you need to tackle. Thank you.
Thank you so much. Thank you so much, Doctor. You mentioned something that I think is very critical that we tend to take for granted, talking about a mother not being able to latch. This is something
Yes.
that I personally also struggled with.
Yes. Yes. Yes.
And
Yes. Yes.
abroad you see a lot of people talk about lactation consultants
Yeah.
and
Yeah.
this
Yeah.
and that.
True.
But in Africa, we don't exactly have those. We just have the midwives, and they're like, don't you know how to do it? Sometimes they can be a bit hostile.
Yes, yes,
These are things that I believe need to be integrated into childcare, into not just postpartum care where the mother just goes, are you fine, is child fine? But you need to
yes,
integrate those things, that at certain time windows you check in with a woman. Are you lactating well? Is the child latching well? Is the child
absolutely,
growing?
absolutely.
Because I don't know how the postpartum care is in India or Nepal, but in my own experiences in the places I've lived, postpartum care is you just come 6 weeks after you've had a baby for a follow up. So there's no checkup maybe a few days after birth to see if the child has gained back the birth weight after losing maybe about 7 to 10%, or if the child is, lactating well, if you're lactating well, if the child is latching well. All of those things go on for 6 weeks, and 6 weeks is enough time for a child to become malnourished, to become underweight, and then to become exposed to diverse infections. So I think I will just go to the next question and ask, Doctor, in your professional experience, have you come, face to face with this vaccine hesitancy that we've been talking about? For instance, there was the rollout of the HPV vaccine in Nigeria, and there were social media, these broadcast messages going around. Don't take it, don't take it. It's poison for your children. They want to make your children promiscuous. Don't give them. So, have you come across vaccine hesitancy in your practice, and how did you manage that?
So, first of all, uh,
Hello?
I think there's a lot of background noise. Uh, yeah. So, first of all, I would like to say that in 2019, WHO uh, mentioned that vaccine hesitancy is the top 10 emerging global threats. Among the top 10 emerging global threats, one is vaccine hesitancy. Now, coming on to my experience of vaccine hesitancy, I've seen a lot of vaccine hesitancy in various aspects, and I can give you some examples. We this became a hot topic at the time of COVID. Because there were a lot of misinformation, disinformation, and you also mentioned malinformation, or what we call rumors. So vaccine hesitancy, and we also saw this in new vaccine introduction, because in context to Nepal, we saw it in a very less amount, because the vaccine uptake in Nepal it's highly robust. The uptake is quite high. So in the initial stage of COVID, we did see certain pockets of areas, certain communities, you know imposing that we do not want to take vaccine. But once they started to realize, through different awareness programs, what are the consequences of these diseases, these illnesses, the drive immediately, accelerated. So how should a vaccine hesitancy be handled? It's a very important question, and what I believe is vaccine hesitancy is it needs a multifaceted approach. It should go beyond providing information, and it should involve building trust, addressing the psychological aspect. And what we did is that we advocated vaccines through vaccine champions. We involved community leaders, religious leaders. We did community engagement programs. We did different motivational interviews, especially for, let me give you an example for HPV. Nepal launched HPV vaccine in 2025, this year in World Cancer Day, in the month of February. And we saw a lot of children, a lot of mothers having issues regarding infertility. So these infertility issues, that uh, the adolescent girl would not be able to marry, due to infertility, once they are inoculated with the vaccine. So this kind of aspects were handled so beautifully through social behavioral interventions. So that allowed mothers and community to build trust. Motivational interviewing and promoting accessible and culturally sensitive information. With vaccines we see a lot of fears due to side effects. This has to be addressed uh, in a very concise, in a very in a very culturally acceptable manner. So these are my experiences for vaccine hesitancy. We also saw vaccine hesitancy during one of our programs to see the urban slums. So in the urban slums we saw that vaccine hesitancy was mainly due to the COVID. So COVID led such a mistrust among the community that it imposed parents not to allow children to take the routine immunization program. One more example I have is during the COVID, we saw multiple outbreaks of different communicable diseases, vaccine preventable disease. One of the important outbreaks was measles. And in India, Yemen, Nepal, we saw sporadic outbreaks of measles. But measles was handled through a well organized socio behavioral strategy. We have currently a based strategy, a based approach uh, in handling vaccine hesitancy among communities. So I think WHO has set it very beautifully, how one can imply different strategies. So the key element is how we can build trust. A
Hmm.
lot of trust mistrust has been due to the severity of diseases, due to accelerated development programs of COVID vaccine. People are still having questions like, how can a vaccine be developed in a year or a 2 year span when it used to take roughly 10 years to 12 years. So these kind of queries, why should we take vaccines which are so early developed? It may not be good for us. It's more like a poison that you mentioned. We don't want to take vaccines which is just made in such a short span. So I think when a policy is developed in order to address these issues, one needs to be a very holistic. These days we have to involve socio behavioral interventionist in particular programs. So so
Hmm.
so so these are the message I want to give the audience, that you know it has to be managed in a very very multifaceted manner.
Thank you very much, Doctor. And I want to say that this session is recorded. It will be on our YouTube channel for replays so that we can put more insights for those who are on.
So
And
I would like to add on the pointers of hesitancy. I
okay,
don't know if you can hear me now.
yes, we can hear you. A bit of
Great.
background noise, but we can hear you.
Oh, sorry. So among the things that on the vaccine hesitance that I think I've experienced in my country is during the COVID-19 season, where unfortunately Tanzania we are very late to accept the COVID vaccine, and unfortunately the hesitance not only in the vaccine related to COVID but also in other uh, routine vaccination for the children. So when you see like from the community, they will not like to be vaccinated from COVID, but they will not be able also to be vaccinated from other any kind of routine vaccination. This will bring a very big impact in Tanzania. We had a lot of outbreaks, and especially again from the measles, and it needs we had to put many efforts on how to help the hesitance to reduce. Among the things that helps the hesitance uh, to be reduced, and then to the community to come back to the normal kind of uh, uptake of the vaccine is the community dialogue. So we had to talk with the community on exactly what are the issues regarding the vaccine, what are the safety issues, what are the benefits, and what are the anticipated uh, side effects, and how to report them. So the transparency in the vaccine is very important for the uptake in the community. But also, healthcare workers need to educate the mothers on the benefit of the vaccine. If a mother will not understand why should I give a three injectable at once for the baby and another oral vaccine to the baby, it's not easy. And actually, they will have a lot of side effects. They will have fever. They will be crying the whole night, and it's not easy for the mothers to take the vaccine. So I think that is among the things that uh, we need to know as globally, that transparency in the vaccine also helps to improve the vaccine hesitance. Thank you.
Thank you, Doctor. I think you've answered my next question regarding motivations and that have affected increasing vaccine uptake among communities. Like you said, previously, being transparent about the anticipated side effects, open and educating caregivers that these are the things to expect when you give a child vaccine. Yes, vaccines they protect children from more severe diseases, but they can sometimes have side effects as well. And Dr. Navneet also mentioned community engagement, where we engage communities and also policies like the policy that was passed in Nepal that for a child to start school, you must have taken vaccines up to 2 years old, which I think is a rather um, it's an incentive to ensure that all children are vaccinated. But I would still like to have both of you shed more light in terms of vaccine side effects. Vaccines work, no doubt, and they are proven efficacious in preventing diseases. Like you mentioned during COVID, sometimes it was not just that caregivers didn't want vaccine, it was that there was a breakdown in the health system, so vaccines couldn't reach the children that needed them. So there were outbreak of pockets of measles outbreak here and there. So how do we um, educate caregivers that yes, vaccines work, but they have side effects, and how do we really get on the forefront of preventing vaccine-related misinformation, such as where people say, "Oh, vaccines cause them," and there are people that really have anecdotal evidence that, "Oh, my child." I saw a social media post recently where the mother was crying that her child was crying up until the particular or a vaccine release, and then the child stopped talking, stopped walking, and a number of people are saying, "Oh yes, that it happened to them." To really get in the forefront of this, because I understand a lot of research has been done that has proven that vaccines are not linked to autism, but people still believe it. How do we onboarding? How do we unpack all of these things that are causing vaccine rejection? Dr. First.
So, so I think I'm not being able to. I'm getting a lot of noise. A lot of background noise is coming.
I'm not sure where that's coming from.
Hello. Yeah, can you
Yes,
hear me? Yeah.
yes, I
So
can hear, and there
yeah.
seems to be no
So
background noise.
yeah. So what we have to understand is that this rise of infodemia, it has come across social media, and we have to understand the fact that this will exist. It will exist. When you have digital platforms, where
Yeah.
digital platforms of information sharing, one must understand that there will be a sort of misinformation and disinformation that people have to live with. This was not an issue 10 years back when there was no advancement of digital health. But now with the improvement with access to social media, one there are a lot of misinformation without any without any proven fact, that there are these side effects issues. So coming on to your point, how can we educate, and how can we educate the community in respect to side effects? So I think the best answer is, like Dr. Angela mentioned, is a community dialogue. A dialogue should be done particularly by healthcare professional. A healthcare professional having transparency of the first, the healthcare professional themselves need to have complete details about the vaccines through evidences, through the right channel of information. You know, if you see, there are a lot of things that can be preached, but which is the right information? So I think this has to be taken by vaccine advocates, vaccine champions. These are the people who will guide towards, you know, uh, how misleading informations can cause serious threat. So I'll give you a beautiful example. I think in country like India, one of the major efforts for global polio eradication was
Mm-hmm.
using actors. Those were very popular actors. They were the face. And a lot of the people started believing. So you have to understand that one of the motivational aspect for the community, and you spoke really well about, you asked about the fear of side effect. Fear of side effect has to be well addressed in the community. We have to
Mm.
vaccination campaign is that side effects of normal side effects are bound to come because it's a local reactogenic effect.
Yeah.
But in case of something which is unsolicited, something which is out of the normal phenomena, this has to be well explained. One has to report AFI. Surveillance unit has to be active. you know what is solicited and what is unsolicited, what is AFI of special interest, what is AFI following immunization program only. So these kind of things has to be well addressed, and it needs a complete team. It cannot be done by a single person. It cannot be
Yeah.
done by a group of people. This has to be at a healthcare system level. System has to work in developing these enactments. So so fear of side effect has been one of the common issues with all the vaccines. We talk about measles. Injectable measles are leading to intractable shrill cry, mothers complaining and coming the next day post vaccination. So so, so so these things has to be well addressed. We are seeing a lot of MR2 uh, downfall. The coverage downfall is because MR1, a lot of side effects, makes the mothers parents afraid. Why should I go for MR2? That same vaccine I don't want to take again. My children cry all the time. There is a
Yeah.
local reactogenic effect, so why should I go and take? And we are seeing that in globally MR2 drop rates are high. So these are the things we have to address through the vaccination campaign. There has to be, in case of India and Nepal, we have ANMs, we have female volunteers who work in addressing these issues in the community. So it has to come again from the policy level side and also from the community side. And
How about the reports regarding vaccines and autism? How do we get on that
so
really?
so I think this is a topic from measles. We're talking about autism, which is correlated with measles. But one has to, what I personally view is, before we say the vaccines lead to these things, one has to, a group of committee has to assess the causality. you know Whether this autism spectrum disorder is mainly due to the vaccine. So we cannot rampantly say that, just one fine day, it leads to this, it leads to that. Many things can lead after vaccination. Let's be very honest. Many things can happen after vaccination, and after vaccination the whole blame cannot come to the vaccines. Yes, for that a pharmacovigilance team is necessary, at district level, at local level, at central level. So a community has to sit down in order to say, if there is autism in 1% or 2% or 3% once reported, there has to be a committee seeing different investigational reports, and based on those investigation findings and clinical findings, then we have to assess, when was this vaccine taken. Was it at a critical window, or whether it was after the critical window? So we have a reactogenicity subset, 42 days. If things are happening after 42 days, one has to see it very meticulously, carefully, that this is particularly due to vaccine, or is it due to some other pre-existing illnesses.
Yeah.
So that is still a challenge at the moment, but there are experts in the panel who are working at national and global level to say whether which vaccines have led to what. So
So would you
I
say that,
yeah,
okay, yes, I wanted to say, would you say that it's important that um, research should be done and ongoing to reassure um, parents and caregivers of the safety of these vaccines, and also
absolutely.
to investigate claims of vaccine connection with autism and other side effects, and
Uh,
maybe if there's anecdotal report on social media, it should not just be left and say, oh, this information. It should be taken seriously and investigated
yes,
further.
absolutely, Dr. Bisula. What I personally feel is that when you share any information, it needs to be understood by somebody who is viewing, is that who is publishing this information, from where is the source. Is it by
Right.
just a layman, or is it by some health professional? So one has to, before sharing the information, one has to read the IEs, the SOPs, the technical uh, reports regarding vaccines. So this is information. Without reading technical reports, without reading the IEC material, without reading the SOPs, you just go in the community and speak. It doesn't make sense. You have to know what are the efficacy results that have shown, what is the safety concerns. you know so, and these days in the vaccines we have, labeling. If there is any safety concerns, it is well mentioned, prior to the inoculation. It's already mentioned. So 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 these kind of aspects are very critical for for not only policymakers, and also while you educate and do the training programs, while you train the community, while you train the vaccinators. These are the critical things that has to be mentioned, and it has to be discussed at the time of training. So what we do is, when we train, we try and build in transparency about the efficacy reports, the safety reports, the use handling. Most of the
Mm,
time the side effects come due to mishandling. People
mm,
not knowing how to vaccinate. In terms of subcutaneous and intradermal vaccine, it is still very
yeah.
difficult for people to handle. So still people are giving it IM. So
Yes.
these handling issues may also lead to these side effects. We do not know. So these things has to be retrospectively seen, assessed, evaluated. What I believe, evaluation is very important for any
Right.
immunization program. Evaluation is very important. We cannot just say the immunization campaign went very successful just because I vaccinated this many people, we achieved the target. No, that's not the end of the story. One has to be very vigilant in evaluating how the programs, the impact evaluation that we say. So impact
Yeah.
evaluation is not only with the coverage, but it is also with the different concerns in the community, safety concerns, some
Right.
some other issues. So these things has to be well addressed.
Yes. Thank you very much. So it seems like it can feel a bit like trying to walk a tightrope because you're trying to be transparent and you're
Yeah,
also trying
yeah,
to let them know that this is important to take, because many times when you say, okay, this vaccine, the efficacy is maybe 48%, and they're like, ah, that's low now, why should I take it and
yeah,
go through this
yeah,
stress?
yeah, yeah,
So it's a
yeah.
fine balance trying to
Yeah. So
transparent.
one fine example I have is when I was doing my implementation research on lymphatic filariasis. There was a suboptimal coverage of mass drug administration. I'm giving you an example how vaccination program affected other interventional programs also, because of the vaccine hesitancy. People started believing that, even medications like mass drug administration, that can also lead to COVID, and that can also lead to filariasis. So this was the negative impression. One program has a negative impression on the other program as well. So fears of side effects, this started being, this was alarming once COVID vaccines came in. And I think one must understand, now that there is a pandemic act that has been taken right now from the World Health Assembly, one must understand that why vaccines take such a long period to develop. And one must understand that with the tech advancement and with a lot of, system vaccinology and reverse vaccinology, one can prepare vaccine in 100 days, in less than 100 days. We saw that COVID vaccine was developed in less than 365 days, to be precise 363 days. So now there is a advancement of technology as well in vaccinology. So people should come out of the thought process that no, vaccines can be developed also in short period of time in respect to epidemic threats and pandemic threats. So I still say it is a multi-faceted approach.
Yes.
Hesitancy about anything in a in an era of digital media, in an era of digital uh, health, you have to take a multifaceted approach.
Yeah, Dr. Angela is there. I was wondering if she's still here. Please, can you talk about this as well? About, because I know you've had extensive field experience. So can you talk
Okay.
about this?
About the vaccine hesitance.
Yes, and how to balance being transparent with still trying to overcome it.
Okay. So for sure, the vaccine hesitance. I would say like the transparent is the first thing. Now, if you are able to balance the transparency to the mother, knowing to weigh the benefit versus the side effects issue, like if I vaccinate my child with measles vaccine, 1 out of 100 babies may have a seizure, for example. And but if I vaccinate this baby, they will not be able to get measles, which is a, a, a very bad disease. The mother will understand, because if we don't tell them the safety part of it, Why are you being vaccinated? Why are you not? Why not? What will happen if I don't vaccinate you? These are the issues that they should weigh the benefit versus the risk ratio. So I mean, like when we say transparent, how to balance it in the dialogue is you need to communicate well on the benefit aspect versus the risk issues. Because we know if the vaccine manufacturing process is not, it's not like just a simple thing that we are just introducing the vaccine to the country. No, it is a process. Now, if it was able to pass the clinical trials and it is agreed that the benefit outweigh the risk, then we hope that it will improve. But also telling the truth about the vaccine manufacturing process. It's not like everyone understand how introduction to of the vaccine to the certain country, how is it being done. Some people do not understand, and that's why they feel like maybe my country people are getting some issue, some money, that's why they just introduce the vaccine and all that. But they need to know the reality, that the clinical trials are being done and what is happening and what are the results. That's why we introduce this vaccine. So telling them the process of manufacturing and the introduction of the vaccine to the country. I know it's not something that we should put to individual dialogue, to the community dialogue always, but sometimes it needs an individual dialogue. You know, when you educate a mother, with they say you educate the community. So if you tell one mother, they will tell another one and another one, and this will make the community understand. But if one will have a misconception of it, they will tell one and another one and another one, and it
Very
brings the hesitance to the community. So
true.
that's how I think. Yeah.
Thank you, Doctor. Been an interesting conversation. It's definitely not exhaustive. There's no way we can exhaust everything there is to say regarding child health, immunization, and vaccination. But one theme that I can say has cut across from what Dr. Angela has said and Dr. Navneet has said is the need for transparency. So, for instance, when we say, oh, okay, we have a new vaccine, HPV vaccine, it's very effective, it can prevent cervical cancer, so let's give it to children. We shouldn't just do that and say, oh, we have something, let's rule it out. We need to have that layman communication where we are telling people, the communities, in the simplest of terms that they are able to understand, that see, we have done this, this is how we developed this vaccine, and we know it works, and we want to give it to your children. We don't just say we have it, we are rolling it out. We need to gain their trust, we need to be transparent, we need to communicate, and this is very valuable, and I believe it's something that is worth exploring in terms of policy. And it brings me to my question, maybe the second to the last question for today, because we have just 7 minutes before we take question and answers. So I would start from Dr. Navneet. What uh, do you see as a key step in bridging the gap between evidence generation on one hand, as researchers, and then the clinical practitioners or the health practitioners, including doctors, nurses, the community health workers, and all that, and also the policymakers? It seems like these are three different tracks, but we need to work together in synergy. So, how would you say, what are the steps that you see to be able to bridge? And also, on the other hand, people in the community, because even if
So,
the synergy between us and the people in the community are not carried out, it might just be wasted. So in terms of bridging the gap for effective translation of research to evidence to practice, what would you say?
so for me, what I think is, for the evidence that has been generated, one must know how to utilize the data. When we have certain evidence about certain intervention or certain research has been generated, one has to understand that how can we utilize this data in translating into evidence and policy. So one of the key aspect is engagement. When you have a data, you must know how to engage it with the right people or different stakeholders. That is number one. So we have data health DHES, the information system everywhere. We have so so that is one effective way that you can visualize the data at, to different departments and to different stakeholders. And secondly, I would say community engagement. Community engagement is very important. So, for example, say, like you said about HPV vaccine. So, are we preventing only cervical cancer, or are we also preventing sexually transmitted disease? So, how are we approaching the community? Just to protect against cervical cancer, or also from sexually transmitted disease? What does evidence tell you? Are we protecting against both of these, or are we just protecting against cervical cancer? So data visualization, data forecasting is very important among the community. Secondly is evaluation, which I always say, I always keep this part, that evaluation of any program and intervention is key. One has to evaluate uh, the program in a very efficient manner, in a very subsequent manner, from taking sometimes as I mentioned, impact evaluation indicators are coverage, safety. These kind of key issues are evaluating process. And then at the end, I would say long term impact. So, for example, say I introduced pneumococcal vaccine in the routine immunization program. So I would see how much cases of decline is there in pneumonia while I evaluate, and in long run, how much the burden of pneumonia due to pneumococcal has decreased in childhood mortality. So this is the process that policymakers need to understand, how we can use evidences. You have you have pneumococcal vaccine. How can how is pneumonia prevented due to pneumococcal? What are the deaths? Has the death rates declined? And overall, among all the childhood deaths, has there been a significant reduction in the burden? So this is how I think research should be translated. Thank you.
Thank you very much, sir. I really like what you said in terms of communication. There's the tendency for researchers, you've done this beautiful research, you have it published in an high impact factor journal paper,
Yes,
and you
yes,
just
yes.
so
Mm,
we need to ensure that the community engagement we are doing is not just going to the communities. I think we need to engage online communities as well. So
absolutely.
aside from publishing our papers, in the very complex scientific technical words, we need to break down and say we've done this research and we have found this very
Yes,
simple and Twitter,
yes,
Facebook, Instagram, all the social media platforms, and also
yes,
on the long monitoring. We say, oh, in this community, because of the introduction of pneumococcal vaccine, children 0 to 5 used to have a maybe death rate of 5 per 100,000 births, but now it's zero. These are things that generate add evidence based, factual evidence for people to see and to continue to increase the uptake of vaccines and other interventions that improve the health of children. So, Dr. Angela, would you also like to say something on how we can bridge the gap between practitioners, researchers, policymakers, and the community that we are trying to serve in terms of health?
Thank you, Risola. So I'm almost in the line with Dr. Navneet, but I'll take the first thing like the from the start of the maybe the research when you are starting it, the introduction to the community. The community should understand what is being done. The ownership of the community should start from the starting of the research. But also, when the researching results are coming up from the practitioner, the policymakers should be involved in the process. And now, when we come to the recommendation of the research, because the implementers are going to be the practitioner and the policymakers for the sustainability. So the research should be able to accommodate all these three groups together from the start to the end to the recommendation part, making the champion from these all the groups. If they have ownership of it, it is easy to implement them. But also, when you are a researcher, sometimes you may have the recommendations that are not actionable to the community or to the policy making. So when you involvement of all the three groups will make the actionable recommendation and the actionable results. So for me, I would say like the to bridge the gap is the best involvement from the start to the end. And if you do that, it becomes easy, and everyone will be able to see the results and the implementation aspect.
So here, hello, can you hear me?
Yes, yes, we
Yeah,
can hear.
yeah. So there's something very beautiful, implementation, based embedded research. So one has to embed research into implementation, and like Dr. Angela mentioned, there has to be involvement of community ownership, and all of this can take place through implementation research. I think a lot of operational research are in focus at the moment. Clinical researches are focused at the moment, but now there is a time that we can strengthen implementation research once we involve multiple stakeholders. Once we have a report and once you have a finding, you can integrate within the system for improving the health outcomes. Like I said earlier, it is very key. These days we shouldn't make research for individual interest, but now the interest should be at large. I think that is the thing that researchers need to practice, that the evidence needs to be embedded. It has to be embedded within the policy, and this is how we can strengthen better health outcomes. Thank you. Dr. Bisola, I think we can't hear you.
Oh, sorry. I was saying that how do we now ensure that this research evidence that we have generated are embedded into policies? And also, while you answer the question, Dr. Angela will answer as well. How do we ensure? Because as researchers, we are not exactly the policymakers. Maybe on an institutional level, we can be policymakers in terms of maybe as a doctor in the neonatal unit, you have found out this particular medication works better, and then you want to give it to children and make it a policy, which is fine. But how do we ensure that the policy, this evidence generated, is upscaled on a larger scale, maybe worldwide, nationwide? Of course, we know these things work, but how do we ensure that the policymakers take them? Because we are not exactly the policymakers, the hierarchy is different in different countries. So that's my question. And
So
then give you give us an example, a policy that you have that was of great impact child mortality. Thank you.
Okay, thank you. Can you hear me?
Yes,
Okay,
doctor.
Yes, we can hear you.
great. So, ensuring that the findings are going to be implemented, are going to be embedded, and they are going to be actionable. I would say, as first, involvement from the start. First, is it a priority? Because not everything that a researcher would think of it may be a priority to the policymakers. But if it is a priority, if it is not a priority, maybe in the future run, it might be a priority. So is it an emerging thing? Is it a public health importance aspect? Okay. And now we have the results and we have the recommendation that we wish the policymakers to take into accountable. Uh, the issue here is uh, the program implementation of the results. So the policymakers, as they were involved, automatically they will give the recommendation that are implementable and they will be answerable for them. Okay. So I would say like involvement is the key issue for it to be embedded and to have actionable results. But also I would give an example uh, uh, of the of how in many countries working especially on the research aspects. So we have example of the issue of apnea of prematurity, which the drug of choice was caffeine citrate. But again, the researchers started to implement it like, will it be able to work in our country and all that? They start working on it. But by the time they are starting, this was not a priority. But we see it in the long run, the neonatal mortality are coming up. So automatically the neonatal respiratory condition are needed. This is a drug to help the neonates to be able to breathe of apnea of prematurity. So for it to, the results came up and we see that the caffeine citrate helped the neonates to improve. And our neonates are dying for respiratory condition. So automatically we will take the results into actionable and now making that sure we are able to procure enough drugs for the country to be able to work, to be able to distribute it to the facilities, and the neonates can receive and the death and the mortality will be reduced and morbidity. So I would say that it was from the involvement and see the priorities, but also there are technical working groups. The researchers should not be involved only in the as academician. They should be involved as the technical working group in the policy making aspect. So we have the RMNCH, we have different types of the department in the ministries. But again, does the technical working group involves the researchers to the to give their results and help them to implement? So it's a cooperation between all the groups. Yeah, I'd say that. Thank you.
Thank you so much, Dr. Angela. Dr. Navneet, can you answer the same question and also give us an example of a policy that was implemented
Okay,
that
so
reduced
I
the
think
morbidity?
I have many examples to say, but before I give the example, I would like to say that what we are seeing a trend is that there is a disconnect between the researchers and the policymakers.
Absolutely.
In many of the low and middle income countries, we are seeing these aspects, and I think it's high time that one must understand that what we are practically doing this research for. What is the long term implications of this research? How is it going to benefit the people? and
Yes.
this has to be well integrated with the policy. So I think one of the great example that I can give you is that uh, through the learnings of zero dose, I think country like Nigeria, India, they are one of the key hubs for zero dose children.
Children.
And
Right.
yeah, and what we saw over period of time, that when we saw that there was a high rise of zero dose children in these countries, countries started to build in strategies and frameworks in order to combat these issues. So let me give you an example of India. So in India, uh, can you hear me?
Yes,
Hello.
yes. Yes, we can hear you.
Yeah, yeah. So India had the leading zero doses uh, in the world, and in 2 years time. So when we talk in 2021, India and Nigeria was head to head in terms of zero dose, but India preceded because it's a large country in comparison to, and the birth cohort is the largest. So
Mhm.
what India did is development of digital platforms like UWIN, help them to track the zero dose children in even the fragile to marginalized communities. So and then we saw a significant decline in zero dose, and also the community acceleration of vaccinating, identifying these children and vaccinating them. So from we saw almost from 5 million children to decline up to 1.3. So there has been a significant decline, and we are now reaching up to the immunization agenda, to reduce zero dose children by 25% until 2025, and 50% up to 2030. That is one example I can give you in context to India. But there are another example which I would like to give is for typhoid. We in Nepal, typhoid incidence rate is nearly around 300 cases per 100,000 population, and the economic burden is quite high. So it accounts to almost 200 200 to 250 to 300 US dollar, which is less than an average income of the family. So when these kind of high burden diseases existed, we are now assessing the economic impact, the cost burden. So these kind of analysis work is going on, and as I said, the impact evaluation needs to be assessed in different domains. So not only we are reducing the disease, but what is the economic cost? Has there been a decline in the hospitalization rate due to typhoid? So this kind of analysis is needed, and this has to be preceded with policy making capacity. We introduced a lot of things, we introduced a lot of implementation. It looks very good and it looks very hyped up, we are introducing this, we are doing that, we are the best. But at the end of the day, as I said, one has to see the pre-status and the post-status after introduction. Has it come? Has it brought impact? So this is possible through academia, industry, and policy level collaboration. This cannot be done singly by the policymakers. Policymakers need evidence, and for academicians to make evidence, they need intervention that needs to be developed by certain manufacturing companies. So there needs to be a cohesive environment where all of these can work in tandem, and bring in a proper connect to improve outcomes.
Thank you so much, Doctor. It's been a very insightful session. I want to apologize that we've gone a few minutes over time. It's
Yeah,
a conversation that, if we keep talking about it for
yeah,
hours, we still can't exhaust it. So
Yes.
thank you so much. I was going to ask about what you think are current research gaps, but you already answered that in terms of evaluation. When we roll out something, some intervention, we need to evaluate how effective that was and also share it with people so that it can encourage them to continue to adhere to taking these interventions and thereby reducing child morbidity and mortality. So before we close, we have some Mary. I hope I'm pronouncing your name right. You want to give a contribution. Thank you for joining us today. Can you give
Yeah,
your contribution, please, in one
yeah.
minute?
Okay, yeah, sure. My name is Charles Chibisi Ehime. I'm from Nigeria. Currently working on advancing digital solutions for improving equitable, efficient, and affordable maternal child health care in Nigeria. In respect to the discussion we are having, it's quite interesting. I've kind of observed one of the gaps amongst what has been identified in this section. One of the key things I think most researchers lack is the skill in lobbying. Sometimes when you say lobbying, most people think it's like you have to come and pay bribe, you have to come and give money. No, it's just to like identify areas where these politicians, especially in low and middle income contexts, you know how these things works. That as a researcher, no matter how fantastic your work looks, and if it doesn't appeal to that politician, it's going to be left on that table. Nothing is going to move, no matter how fantastic that result is. So how do we now kind of fuse that gap? That gap between the policymakers, the politicians now, and the researchers. And one thing I would say is again translating our scientific research and results to simple lay languages that
Okay.
every layman can understand, and they're kind of identifying those key factors that could be like a driving force for a politician to say, if you can implement this, your name will be out there for it. That's a way to kind of lobby. We must find a way to lobby some of these initiatives. So if we don't do that, at the end of the day, you will see that no matter what you do, is not going to be a priority for the politicians. No matter what you do, it's not going to be a priority for the politicians. So, but we must find a way of fusing, what we do and make it appealing to the politicians so that these policies can, pass, and effect the real change in the community that we want to see. Over.
Thank you.
So
Thank
I
you
think
so much, Charles.
I
That's
think
really important.
I'll just like to add on to what you said. I'll give you an example. I think a researcher needs to understand prior to building the idea, before having the ideation and the concept building, is that what is priority for the region. I'll be very honest and I'll give you an example. So currently, we have involved various stakeholders from Southeast Asia in developing a research priority for immunization, for research priority, and there were set of questions, tools that had been developed, and then we got the top 10 research priority. There were around 30 questions, and we got around top 10, which has been already set now. So once the research priority is set, and where intervention can be enacted, a researcher has to be very, very cautious enough, like you mentioned, like it may end up in the table, but it may not. You may have done your PhD, you may have done your thesis program, or you may have done an independent research. It can land up until the table only, but what after that? So it is very important for the researcher to understand what is the priority of the country and what is the priority of the region. We cannot do unnecessary research which has no meaning, which cannot be translated into policy. This has to be understood, well understood, prior to starting of the research. That is why there is a lot of disconnect.
Sorry,
So,
Dr.
so, so,
Navneet.
so
Can I jump
that's
in
my,
here?
yeah, yeah.
I
I'll just,
wanted you to just answer. I see that you're already going in that direction. So I want
yeah,
you to answer this question as the closing question for the day. So
yeah.
if you came face to face today with maybe the president of maybe Nepal or India, and he's like, Navneet, I need a policy from you to implement as regarding child health. Tell me something. What would you tell him that is the pressing policy need or the gap that you've seen that you would tell to the maybe the president or the legislator, whoever it is?
So I think my role would be, as a researcher, would be to understand, in respect to child health, is that I would first try and understand the trend of diseases over the past 5 years, where the burden exactly lies. Is there a need of improvement in the program, or do we need new interventions in the program? That is something that I would like to address. First, I would like to see it
Okay, in
myself, where
terms
the,
of vaccination.
yeah. So for vaccination, I would like, in context to Nepal and in context to India, there has been introduction of rota new vaccines, but I would like to emphasize mainly on life course approaches. And also try and speak about, you know, measles. I would like to talk on the high burden disease focus. Like, for example, in context to India and Nepal, we still have recurrent outbreaks of circulatory vaccine derived polio. So, I would focus on supplementary immunization activities that leads to outbreaks. So, intermittent uh, outbreak planning management, that would be something that I would like to speak on, because we do not know, there can be outbreaks at any time. So that is something I would say. I would always see the coverage. What is the coverage trend? And if the coverage trend is low, I will be very specific focus I would give for that particular vaccine antigen. uh, the other aspect I told you is the life course aspect, the zero dose aspect, and so these are the key things for under five, that a new vaccine introduction. Obviously, I am sure that many other African countries are still on the verge of introduction of NOPV, and I would say NOPV is one more genetically stable oral polio vaccine. So this kind of interventions, in context to Africa, in context to like yellow fever outbreaks we are seeing even in Africa. So emphasis on yellow fever vaccines, emphasis on malaria vaccines. I think you are introducing malaria vaccine and you are also introducing. Now we are working on chikungunya vaccine, dengue vaccine. So new vaccine introduction pipeline should be discussed at the current need of the country, what is available in the market, and zero dose vaccine hesitancy aspects. If there are pockets, I would like to go work with the community. So these are the key highlights I would give a brief any high level policymaker.
Thank you so much, Dr. Navneet. Dr.
Yeah.
Angela, so if you were face to face with the president of Tanzania and they said, oh, tell us one policy that you would like to see implemented regarding child health or vaccinology or vaccination, immunization, what would you say?
So for me, I would think of the two things which are interacting. So the neonatal mortality is causing 50%, almost 50% of causes of under 5.
Yeah.
And sepsis is among the commonest cause. Can we have think of the causes of sepsis, which is purely related to the sepsis that can be prevented by maternal immunization. So, should we think of maternal immunization as a preventive way of reducing sepsis in neonates and reducing almost one third of the causes of under five? For me, I would think that because it causes a big impact now, especially in low and middle income countries, and I'll come up with that. That's my thinking because the big thing.
Uh, yeah, so
Thank you so much. Thank you.
I
Thank
think
you, Dr. Navneet. Thank you, Dr.
thank you so
Angela.
much.
We are
So,
out of time,
yeah,
unfortunately.
yeah, yeah, yeah. No, no,
So
that's okay.
maybe
But
we'll continue
I
the
think at the end,
conversation.
at the end, I'd just like to say is currently vaccination is more important. I think we have just been talking about vaccine development, new vaccine introduction. You have everything, but it has to run in parallel. Vaccine development, vaccine uh, development with vaccination. We saw a great example with COVID. There was a vaccine inequity, and there was no equitable access to vaccine. So one has to understand that vaccination is really key, not forgetting the fact that vaccination is the end pathway to prevent childhood mortality. So that is something, that's the message I would like to give people, that please, all the people who are working in policy or working in research, please embed it, and uh, give back to the community in building policy.
Thank you so much. Thank you once again to our guest speakers, Dr. Angela, Ulotu, Leonard, and Dr. Navneet Bichha. It's been a very insightful session. Thank you so much. We already went over time, so I think maybe in 3 minutes we can just take any questions from anyone. If you have questions for the panelists, we have about 3 minutes. You can put it in the chat or you can unmute and speak. Or if you have any comments, please feel free to put in the chat or unmute and speak very briefly, please. Anyone, if you have a question or a comment or you want to share from your personal experience on the field. Okay, we have a question here from Mr. Charles. So Dr. Navneet, you answer first, then Dr. Angela. He says, how can community-based interventions be better integrated with formal healthcare services to improve outcomes in the first 1,000 days of a child's life? How can we integrate community-based interventions with formal healthcare services? Dr. Navneet?
I think here one of the key, like a lot of interventions are already there. Like when we started the talk, we spoke that what are the different burdens, what are the top 5 killers. We spoke about pneumonia, we spoke about diarrhea, we spoke about infectious disease, we spoke about malnutrition. So most of the community-based interventions already exist. You like for I'll give a very good example of Nepal. Uh, for malnutrition, we do not go for supplementary products that are already available in the market, synthetic supplements, but we have an in-house what we call Balvita. It's made enriched with different uh, you know nutritive products, and this has been already implied in the policy now. So these are the community based interventions. It is developed in the community, and now it is developed as one of the source for this Balvita is now given across Nepal. to encounter malnutrition, severe acute malnutrition. So this is one intervention example that I can give you. The other example from community that can be integrated into system is this hand washing techniques, this kind of hand washing techniques also, this can also be integrated into formal healthcare services. So female health volunteers, this is a great example. In country like Nepal, India, we have a specialized females that work in you know uh, in the community, the female work health activists. So they have a set population of 1,000, and they look after this 1,000 population in respect to every, in terms of vaccination coverage, in terms of maternal health, in terms of any kind of health risks. So any intervention that is needed from them, it is embedded directly into the healthcare service. So these are the two examples that I can give you at the moment.
Thank you so much, Dr. Navneet. Dr. Angela?
Thank you. I think the question is very nice as it focus on 1,000 days. Uh, for me, I would say like the first thing is to look at the burden, but the burden in which perspective. So the postnatal follow-up of the neonates. So if we wanted to integrate the community in healthcare services, the follow-up from the neonate who is being discharged from the 24 hours from the third day of life should be known to the community, and the community should make a follow-up on these neonates as workers to the health system. They should be part and parcel
Yes,
of the community system. So the package for the community health workers should be very effective to make sure that it is has a good connection with the healthcare workers. But also looking at the referral system that is should be effective. If we don't have a good referral system from the community to the facilities, to the health facilities, then that is nonsense, because they had to reach areas children are dying, and the cause is because they can't access the health services. So the referral system
Yes.
should be established that is effective. But also the last one I could say is the community early childhood development services. There are communities that have been established the how to educate the mothers in the community, making like the programs in the community that the healthcare worker can come and can be able to educate the mothers in the community. So those are the issues that can make the two things going together and improve the services. Thank you.
Thank you so much. A round of applause for our panelists, our guest speakers. Thank you so much. You've really shared with us of your wealth of knowledge, of experience, and we are so grateful for that. Thank you so much. And thank you, Mr. Charles, for the contribution and the question. Thank you, everyone, for joining. I want to apologize once again for going over time. Thank you. And like I said, this is FIRAT. Please feel free to follow us on YouTube, and also you can connect with us on our website. So, and also you can still register so that when we have the next installment of this expert dialogue series and other offerings from the institution, we can share with you in your email. So you can check out our website on firat.rw for the other places where we work and how you can engage with us. So the next installment will be in June. We have this once a month. So it will be in June, Friday, June 27th, 2025. And we'll be discussing preconception care. examining it as a missing link in maternal and child health services. Thank you so much, Mr. Joydeep. I see your question. Unfortunately, we are out of time. We might have to connect. I would share our email so that you can connect with us and we can discuss further about this. Or maybe after we have ended the session, you can hang on a bit if our panelists still have some time so that we can answer your question. But most of these things we've discussed is how to address vaccine hesitancy among parents. Thank you so much once again, everyone. We are honored that you joined us. We have also the recording on our YouTube page so you can watch to, learn and share with people. Thank you and enjoy the rest of your day. And it's a
Thank you.
bye for now from us. Thank you once again, Dr. Navneet and Dr. Angela. We are so
Thank
grateful.
you.
Thank you so much. Bye.
Hello, Bisola.
Yes.
I was thinking if we can get a nudge on our email in terms of the registration. It also helps people to kind of fast track in terms of the linkage, like getting a nudge from the institute on our email.
Oh, before the session.
Yes, or even as you mentioned about registration, if that also comes more or less like a reminder to some persons, they want to do maybe at that particular point in time, maybe network, or they might be on transit and they will kind of forget. Like me, I've been following up, like even like if I joined late, but I've been watching on the time, kind of I missed.
Oh, I
Yeah,
see, like a
so
reminder email at the time the session
exactly.
starts.
Exactly. Maybe like a 1 hour before the section, or maybe a day before the section to say, remember tomorrow is our section. So that's kind of, it helps one to kind of keep track.
Okay, we'll note that. We'll
Okay.
try to incorporate that. Thank you so
Thank you.
much. But I hope you
Thank you.
registered so that we can be able to easily mail you.
Yes, I think, but I will still do that again, but I think so.
Okay.
I will do that again.
Thank you
Yeah.
so much. All right.
Yeah.
Thank you. That was an insightful contribution that you gave.
Yeah. Thank you.
Thank you. Bye. Enjoy the rest of your day.